Thank you. So I'm very quickly talking about the Prompt Care program of work. And firstly, I'd like to acknowledge the substantial number of people who've been involved in this program from Southwest Sydney and Illawarra Shoalhaven LHD, which are listed there, also from the Cancer Institute, and acknowledge the funding from the Cancer Institute and the Bupa Health Foundation. So firstly, what is Prompt Care? It's the first Australian integrated eHealth program, and that's really the main thing. It's integrated. It uses systematically collected patient-reported outcomes to inform clinical care as well as self-management. So the reason we developed Prompt Care is we still know that there are large numbers of patients who report significant unmet needs, and that much of the toxicity is not being detected. So we don't routinely collect information about unmet needs, anxiety and depression and so on, which means that a lot of the issues remain undetected and therefore untreated. Importantly, there's really good evidence now that there are significant clinical benefits to implementing a well-designed and routinely implemented electronic system for collecting patient-reported outcomes, with important outcomes including improved quality of life, survival, completing chemotherapy treatment and reduced admissions to hospital. So really important outcomes. And finally, if we had such a system in place that was systematically being implemented, we could reduce the need for as frequent follow-up, face-to-face follow-up for patients, and thereby reducing the burden as well as the cost overall. We also know that at the international level, patient-reported outcome measures being collected routinely is really being talked about as a very important thing to be doing. So we're very much along with that trend. So just very briefly, the Prompt Care model is based on three major arms. One is to support self-management, the second arm is to support clinical care, and the third arm is to accumulate data for research purposes. And I'll talk about each of those briefly now. So the first step is the Prompt Care assessments. So how do we collect the patient-reported outcomes? At the moment, these are done approximately monthly, and they're from the time of diagnosis and commencement of treatment, essentially forevermore, so it's not a one-off assessment. These are done either using a tablet in the clinic, or we send an email to the patient where they can click on a link and complete the assessment from home. In this first phase of our work, we are collecting the distress thermometer and the checklist. We're also collecting the Edmonton Symptom Assessment Scale and the Supportive Care Needs Survey 9-item screening tool. So we then use that data initially to support self-management. So at the end of the survey, the patient's told they'll receive links to self-management resources. There are 5 pages that host these links that sit on the EviQ website. You can see on the top right up there what one page looks like. Patients can then click on any of those issues in that page and have access to the resources, whether they be a PDF or an audio resource, for example. If they don't identify particular issues like in the physical domain or the practical domain, they don't get those pages. So we're trying to reduce information overload for patients as well by doing some tailoring to their needs. The second key function is facilitating timely care. So you'll see there that the clinical team receives a copy of a summary report, which is the one on the left, and a longitudinal report if the patient has done more than one assessment. These are available to the clinical team in real time, and they're fully integrated into the existing oncology information system, which in our 2 LHDs is Mosaic. So this will help facilitate continuity of care with all of the care team having this access to the same information. After much work, we went with a model where we basically highlighted the issues of concern in red, so the care team can very quickly look at the issues, identify what's of concern, and we also provide recommendations in that yellow box up the top about what kind of care or referrals might be appropriate to make. We also want to facilitate shared follow-up care by GPs, so we've developed an end-of-treatment summary and care plan, which is auto-populated from the medical record. That was developed in consultation with GPs, and it also includes a link to the EviQ website so they can follow up on any particular treatments the patient's having, and also providing a phone number back to the Cancer Centre directly if they have any questions or want to talk about any issues that are on that treatment report. We also want to facilitate rapid re-access to the Cancer Centre for patients who might not be coming in for some time, but where 2 of their reports suggest that they have issues that are above threshold. So the Cancer Centre will receive an email essentially saying, please review this patient's report and follow whatever the appropriate protocol is at your centre for following up. So the final arm is to facilitate research. Now, in this first phase, we've been looking at functionality, feasibility and acceptability of the system with a sample of 35 patients and 5 oncology staff. What we found is very high levels of acceptability, and importantly that 96% of patients found the online assessment easier or the same as completing a paper copy, and a large proportion were willing to complete more questions. Patients said that it made you think about issues that you weren't previously thinking about. Oncologists said it gave them greater granularity and specificity about what the issues were and had the potential to save time. We are now in the process of collecting data on 200 patients, and we'll look at uptake, usability, acceptability and resource utilisation. This program, once developed and implemented, has a lot of functions that could be put in place. For example, helping identify gaps in care, adapting it for people of non-English speaking backgrounds. In the future, considering other electronic medical records other than Mosaic where it might be implemented, larger scale rollout, and potential for use with other chronic diseases. Saved by the bell.